And welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dana Poole and Dr. Ashley Thornton, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based.
This week we have a fantastic article to discuss. The article is titled Clinical Utilisation of the Infant Monitor of Vocal Production for Early Identification of Communication Impairment in Young Infants at Risk of Cerebral Palsy, a prospective cohort study. This article was published in Developmental Neurorehabilitation in 2021, led by Dr. Roslyn Ward, along with a wider team including Neville Hennessy, Elizabeth Barty, Catherine Elliott, Jane Valentine and Robin Cantelmore. Welcome to the podcast, Ros.
Thank you for having me.
Welcome, welcome. We are so glad that you're here to join us. As you know, we've been waiting for this article to be published for quite some time. So as soon as we saw the article had dropped, you did get a phone call from us pretty quickly. No apologies there.
Yeah, and congratulations on the publication, Ros. I know how much work has gone into, not just this publication, but your whole body of work. You've really put, blood, sweat and tears into that. And I think this publication is just the first in quite a few vital pieces of this big research puzzle, isn't it?
That's correct.
Yeah. And to assist us this week on the podcast, we've also got another special guest, Lucy Fitzsimons, who is a speech pathologist currently based in a paediatric tertiary hospital in Melbourne. We thought that it would be really beneficial to have another speechy join us to talk about this paper, because there's just been so much interest in this work. So we just would like to welcome Lucy to the show as well.
Welcome, Lucy.
Hi, so excited to be here. Thanks for having me.
So before we get started, I think we probably should do a proper introduction of Dr. Roslyn Ward, or Ros as we'll refer to her in this podcast. Ros is a Senior Research Fellow at the School of Allied Health at Curtin University, Perth Children's Hospital and Telethon Kids Institute. As a speech pathologist, Ros is well known for her work in motor speech interventions, particularly in the area of cerebral palsy. Her work has employed innovative assessment techniques, which include kinematic analysis of the jaw and lips and facial recognition technology. In addition to this work, which has contributed significantly to the body of evidence for motor speech interventions, Ros has also contributed to the International Clinical Practice Guidelines for Early Intervention in Children with Cerebral Palsy, as well as large cohort studies investigating early detection for cerebral palsy. Her passion for evidence-based practice is also expressed through her high level of support for high degree of research students and clinical teams within Perth Children's Hospital, who she engages with to support their clinically relevant research. Ros also runs in her spare time and recently completed a half marathon, which actually occurred during one of our Perth storms. And despite all of the wind and rain, she managed to complete it, which is incredible, in sub 2 hours. So 1 hour and 45 minutes to be exact. And also managed to help a fellow runner out along the way.
Oh.
Superwoman.
We had to put that in there, Ros.
Thanks, Dana. Thank you.
I do remember that storm because I was lying in bed going, whew, I wouldn't be going out there today. And then the next week I caught up with you and you're like, oh yeah, that was the day I ran the half marathon.
That's right. I remember waking up going, am I running this today?
Not only did you run it, you smashed it. Even if I had someone pushing me, I wouldn't be able to run that fast.
Well done.
Yeah,
thank you.
So Ros and Lucy, before we get stuck into the meat of our podcast, I guess, we like to start with a little icebreaker question. So the question we thought we would ask you today is, what food do you dislike the most? Oh. Ros, would you like to start?
Well, I have to say the food I dislike the most is meat because I'm a vegetarian. So
that would make sense.
That is a fair answer. And do you hold meat eating against others?
No. That's totally a personal decision. It's up to you if you want to eat meat. That's not a problem. But for me personally, it's a choice I made.
Yeah,
just to eat.
How long have you been vegetarian for?
Oh, a long time now, since a teenager.
Oh, wow.
Oh, okay.
So not long at all.
No, not long. No.
What about you, Lucy?
I can't stand coriander. It makes me angry if I have some. And which apparently is a genetic thing or something. You either really, really like it or you don't. So it's in my genes. Please don't give me any.
Won't hold it against you.
So like it makes you angry. What does that mean? Like, so you have a curry, someone's put some coriander in there and, you know, you're storming out of the restaurant? Like,
do you tip it on the head?
I just need to take 3 deep breaths, remove it, and then keep eating.
So it's like a proper emotional reaction to coriander.
It
wow.
really is. Yeah, you see, you do get to know people quite well from this.
You do, yeah. I must admit I have a similar reaction to tinned tuna, so which makes the open plan workplace environment a little bit tricky at times. Yeah, because tinned tuna is a go-to for a lot of people.
Very common, that's right.
Yeah, it makes me gag.
Oh, wow. So, but fresh tuna, like, you know, sashimi.
Fresh tuna is great, yeah.
Okay. They almost seem like 2 different things completely, don't
I
they?
think so.
Yeah. One's cat food.
That's how I reconcile it in my head. I'm coming a very close second is tomatoes, raw tomatoes.
Oh,
yeah,
really?
No.
Tomatoes are great. Look, I don't think I have anything that I greatly dislike. As you've gathered from the podcast, I love food. I think about food a lot. I talk about food a lot. I love every cuisine. And the only thing I can think of right now that I don't like is something I've never had before, and it's snake. Like, this is as far as I need to go. Like, something as disgusting as, like, I dislike snakes. They look scary. I don't know why I'd ever consume snake. So that's the first thing I think of.
With that.
Yeah, because I mean, I love escargot. I love frog legs. You know, I love French food, as everyone knows. Like
eyeballs.
Eyeballs? Do people eat eyeballs?
Yeah.
Yeah, well, okay, let me say eyeballs then. Just the thought of it. Let's say that.
Just any kind of eyeball.
Okay. That's as far as it goes, and I love everything else.
I feel like we've learned a lot.
Yeah, well, that's good. Well, because I love coriander. I plant coriander. I'll sniff it and I'll put it in everything in bucket loads.
Just not Lucy's curry.
I'll know that the next time I make food for you, Lucy. Well, shall we get into this podcast?
Absolutely.
All right, everyone. I'm going to go through the PICO format for this very exciting study. So this case control prospective longitudinal cohort study involved 36 infants. 18 infants were identified as being at risk of cerebral palsy at the time of enrolment, and 18 infants were typically developing. Infants were identified as being at risk if they were considered to A, have abnormal MRI findings or general movement assessment or medical history that placed the infant at high risk, B, a referral and acceptance into the early intervention service before 6 months of age, and C, completed the receptive expressive emergent language test and the infant monitor of vocal production or the IMP just prior to 6 months of age. So all children were assessed using the receptive expressive emergent language test or the REAL test, which calculates 3 scores: receptive language ability, expressive language ability, and combined language ability score, and the infant monitor of vocal production or the IMP, which we'll refer to from now on, to determine a child's level of achievement in relation to target vocal behaviours at 3 time points: 6 months, 9 and 12 months of age. So these assessments are all criterion and norm reference assessments. They are completed by a speech pathologist using a semi-structured interview format with the parent as the informed observer. So this study provides the first set of data to describe the longitudinal development of early infant vocalisations in children at high risk of cerebral palsy or diagnosed with cerebral palsy. This data supports the predictive value of infant vocalisations on communication outcomes in infants at risk of cerebral palsy. And whilst infants at risk of cerebral palsy do not differ from their age-matched peers at 6 months for vocal behaviours, there were significant group differences at both 9 and 12 months. The rate of development of early language ability and more complex speech-related vocal behaviours was slower in infants at high risk of cerebral palsy, and 75% of infants with cerebral palsy showed below normal vocal production and impaired language by 12 months.
Wow. There's a lot of information in there.
There is.
And I am itching to get into the details of this paper with you, Ros. But before we do a deep dive into this paper specifically, I know that this work is part of a larger study. So I was hoping you might be able to give us a bit of context about that larger study and how this publication fits within that.
Thank you. Thanks for the opportunity to expand on the larger study as well. I want to begin by acknowledging that this project would not have been possible if it wasn't for the early intervention service at Perth Children's Hospital, in which the study was embedded. The support of the early intervention staff there was amazing, and the involvement of the families as well.
Yeah.
So the early intervention service for at risk of CP was established or extended in 2015, and it is modelled on a collaborative clinical research framework with links to national and international clinical research networks. So now to the broader study. Whilst the paper reports on infant vocalisations at 6, 9 and 12 months of age, the broader study involves continued tracking of these babies until 2 years of age using a range of measures.
Right.
We also had a subgroup of babies that we used a single subject research design, which I know is close to everyone's heart here.
I love it.
They had a subgroup of babies that participated in an intervention arm of the study.
Wow.
Yeah.
That's a huge body of work, hey?
It is. And I know I've seen firsthand how much of that work Ros has taken on and done the lion's share of. And so, yeah, I think it's so impressive what you've been able to do. And I know it's with the support of the bigger team, Ros, but I think, kudos to you as well, because you've done an amazing job. Okay, so getting into the specifics of this study, Ros, for those who perhaps aren't so familiar with some of the different types of study designs that we might use to answer our research questions, could you explain to the listeners what a case-controlled prospective longitudinal cohort study is and why you chose to use that design over some others?
I'm going to answer that question in 2 parts.
Okay. Sure.
So I'm going to take the case control component and then I'll take the longitudinal component.
Okay.
So case control is where you have 2 groups of children. So the population that you're interested in, so for us, it was infants at risk or high risk of CP.
Yep.
And then our second group was typically developing children. And that allows you to form a comparison between the 2 groups.
Yep.
A longitudinal component of the study is where you continue to track those babies at regular time points rather than taking one snapshot in time.
Sure. Yeah.
So that allowed us to see changes in vocalisations over time.
Yeah. So that was the 6, the 9, the 12 months.
That's right.
Yeah.
But actually we went 6, 9, 12, 15, 18, 24. So we had regularly spaced intervals.
Yeah, that's amazing. Okay, so that's a really good description. Have you noticed everything we talk about has got really long words?
Yes, I know. We do like to make life hard for ourselves.
We do, don't we? All right, well, now we know more about the study design itself. I really want to go into a bit more of the background about infant vocalisations. Obviously my background is a physiotherapist, so I know very little about this, but you can see that there's broad applications and we need to have knowledge about this no matter what discipline you are. So I know you could probably, do a whole series of lectures on this, but I guess just in brief, can you just talk through, the development of infant vocalisations?
Absolutely. I find this fascinating and you're right. I could talk about this for a really long time.
Yeah.
And in fact, it's intuitive to a lot of us, but we just don't have the labels for it.
Yes.
And I know for me that sitting in public places like at an airport or waiting in a cafe when you hear a baby crying and those early vocalisations, once you've got the language around it, it becomes fascinating. And rather than being frustrated by the screaming baby sitting behind you on those days when we used to be able to fly, you can start to dissect it a little bit. So infant vocalisations typically follow an orderly sequence of development, beginning with what is regarded as language universal pattern of production.
Right.
So to put some context around that, did you know that there are about 600 consonants and 200 vowels available to us universally?
Wow.
So we're talking about this universal production. Babies are set up for that.
Wow.
And those very early behaviours are reflexive.
Yep.
And newborn parents or caregivers of babies will understand that very first cry and trying to understand, is it about tiredness? Is it about hunger? What is Then what we observe is that over time, the babies have learnt between birth and 9 months to start to tune to the sounds that are specific to our language, and vocalisations become more complex and language specific, laying the foundation for first words.
Yep.
So this increasing complexity is associated with both physiological development as well as experience. There are a number of stages that we pass through, and those stages are associated with time lines of development.
Yep.
And we expect particular vocalisations to occur at these time points. And in fact, we can map those milestones. I guess I could take you through. There are a number of different models of how to classify infant vocalisations and the stages that they go through. For the study, we used a protocol called the Stark Analysis of Early Vocal Development, and that has 5 stages. It would take me a while to go through describing each of those 5 stages, but I think it's enough to know that, one, we can identify them, that we have expectations around when they should occur, and secondly, parents are great reporters on those stages of vocal development.
Yep, that's really important and powerful, isn't it?
Absolutely. And Ros, just to cover off some of the details around the assessments that you used within your study, we've touched on them in the front end of the podcast a bit. But firstly, let's start with the IMP, or the Infant Monitor of Vocal Production. What does the IMP do? Who can do it, and roughly how long does it take to use the IMP?
So the IMP was developed by Dr. Robin Cantle-Moore, and I think it was first published in about 2004. The tool, I think, is a really nice and elegant tool that is really clinically relevant, where it looks at infants' progression from early reflexive vocalisations to the development of early words, proto-words.
Right.
What she has done is designed it as a parent education tool as well, so that it's initially focused on assisting parents to understand the nature and pace of their baby's vocalisations, following the trajectory of development, initially designed for neonates with a diagnosis of hearing impairment or hearing loss.
Okay.
It consists of 16 interview items that are administered in a conversational interview format, and it goes across 3 stages. So the first stage is in that innate reflexive period, and it's the baseline assessment. And that typically needs to be administered before 6 months of age, ideally at 5 months.
Right.
The second stage of the IMP marks a transition to intentional pre-linguistic vocalisations, and around 7 to 8 months of age. This stage reflects the transition to what we call the auditory production loop. So the infant has an awareness around their productions.
Right.
The third stage marks the establishment of the infant's vocal motor competence.
Right, okay.
And that's called the integrity stage. And it's where they're reliable with their vocal motor productions and auditory detection of the temporal patterns of speech. And this stage is called the integrity of the audition production loop. Each interview question has a 5-point Likert scale, or is it Likert?
I don't know. I say like it.
I say like it.
Yeah.
And that's reported by the parents, and the scale goes from never all the way through to always. And the scale allows you to determine the robustness of the infant's vocalisations at the stage for age assessment.
That's so interesting.
I was going to say, thanks for such a great explanation, Ros. As from a speechy perspective, I always thought the IMP was specifically for children with hearing loss. But of course, you know, as you speak more about the measurements that we can take, of course, it would be a tool to flag atypical trajectories of vocal development in other populations. So I think it's a really good assessment tool that we have that maybe could be used even more.
It's a really good point, hey?
Yeah.
Yep.
And I think what I like about this tool is the clinical utility. So researchers have been telling us for a long time we should be assessing infant vocalisations. This can be the gateway to early detection.
Wow.
Yet we were stuck with really complex analyses. You have to record the infant vocalisations and then sit down and spend hours trying to transcribe and decide what types of vocalisations we were listening to. And this tool allows us to get an understanding without that detailed, complex analyses. Having said that, it does require an ear for vocalisations. There is some background knowledge that's required.
Of course, yeah.
So who can do this assessment, Ros? Do you have to be a speech pathologist and have the requisite training in the IMP to be able to utilise it?
You need to have the requisite training in the IMP, and that is available through online training through the e-IMP. But you're not required to be a speech pathologist. You need to be a healthcare professional. I think it's most beneficial if you're actually engaging in early diagnosis.
Yeah,
right.
Absolutely.
And it doesn't take very long to do. I read in your paper, it can, it's something that can take 15, I guess it depends how competent you are and identifying that. Is that correct? So it's quite a short.
It is a short interview, and because it is about tracking development over time, the first baseline assessment, you go in and you ask the parents the questions about their infant vocalisations, and you continue until you hit 2 responses of never.
Right. Okay.
Then the next time that you go back and re-administer the assessment, you go back to your last ceiling item +1 and then move forward from there.
Wow. What an intelligent tool. I love
It is. Yeah, absolutely. And the other tool that was used in this paper is the REAL, or the Receptive Expressive Emergent Language Test, the third version of that. Could you just talk us through the REAL and what that does and what that measures?
So that test is also a test through parent interview. It's the reason why we selected that tool is because it has established psychometric properties, and it went from 0 to 36 months of age, so it covers the whole age range of our study.
Yep.
It's not designed for children who have physical impairment, so it really does require investment in understanding the family and the child's individual needs to be able to tailor the questions as you ask them. But it has established psychometric properties. You get a standard score and a percentile rank, so you're able to track how the child that you're assessing compares with their typically developing peers.
Yeah. So another assessment that is done by interview, and how long does that take?
Again, that varies. So the test developers suggest it takes 20 minutes. It might take a little bit more because you are engaging in an interview with families.
Yeah. And it always opens up stories and crucial bits of information that actually can influence what you want to do.
Yeah, especially if this is the first opportunity that parents have had to discuss their child's speech and language development with someone, that's
really powerful. Oh, thanks for talking us through those assessments. That's the first time I've heard about those assessments. Obviously speeches know about them, but how to apply them in this context I think is really innovative and new. So we're going to hand over to Lucy now. I think there's so much to draw from this, and let's talk about the results, and it'll be great to have your perspective, Lucy, of the things that you really drew from this paper.
Sure. So, Ros, you mentioned that you measured the IMP and REAL3 at 3 time points, 6 months, 9 and 12 months. Can you talk us through what you found at 6 months?
Sure. Great question. So at 6 months, what we found is that there was no quantitative difference between the typically developing children and the children that were identified as at risk. And you might be surprised by that, or you might not be surprised by it, given what we've been talking about before around those innate reflexive behaviours. And so while there is a lot of development that is taking place between birth and 6 months of age, we're not really seeing that the impact of experience and exposure at 6 months.
Wow. I think that is fascinating. I have to admit, you're right. I'm surprised, but I'm not surprised. I can't quite put my brain into which camp I feel that one is in, because I feel like 6 months, maybe what this does highlight is the importance of identifying children who are at risk, so you do monitor them.
That's
because
right.
you're not going to know that at 6 months if you don't have that history.
Yeah.
That's exactly right. If you don't know the history, then you don't know when you come back at 9 months what that shift in trajectory is.
Yeah. That's really important.
And what was that, Ros? What changed at 9 and then 12 months in terms of the IMP and the real 3 results?
So what we saw is that while there was, and I'm going to go back to the word quantitative difference because we're analysing the data more qualitatively, is that between 6 and 9 months, while typically developing children continue to have an upward trajectory in their development. So, for example, on the IMP, they kept progressing through the interview items. So the IMP is set up that you progress 1 item per month. So in 3 months, you expect progression to pass 3 items.
Right.
So while the typically developing children were doing that, the children with CP were not. And what we saw is that, again, at 12 months, some of the kids were still responding to the same question item that we delivered at 6 months. And other kids were moving forward at a slower pace.
And I think that's really evident when you actually go and read the paper, and I would encourage everyone listening to go and read the paper in full and look at the graphs that you've presented in that paper and the real difference you can see in the trajectory and the differences between the groups. I think it's quite powerful. Is that what you were expecting to see?
I think so. And I think, Lucy, as a clinician, you look at it, I think clinicians will go, yep, there's no surprises here.
Yeah.
But on that, what I found quite interesting, particularly not being as familiar with the IMP, and maybe you can talk us through this a little bit more. You speak about obviously in the IMP, you have sort of the question ceiling the paper talks about, which reflects the child's current stage of vocal achievement, and that those ratings are then used to generate a secondary outcome measure, the percentage ranking score, which was then used to kind of compare the 2 groups. But what were the more specific features or factors of the assessment that resulted in the discrepancy between the at-risk and the typically developing group?
Fantastic question. So, and this is, we are now delving deeper into the vocalisations as well. So what we found is that, as I said, the IMP is set up to show that developmental progression. And the questions that we found babies were starting to fall down on were those ones around where you have experience with mouthing, so that as you put an object into your mouth as a baby, you can occlude your lips and you can start to hear consonant-like sounds merging with those vocant sounds, vowel sounds. So the children with typically developing speech were starting to combine those sounds and move into what we call canonical babble, which is that syllable structure we recognise as being word-like, so ba, ba, ma, ma. So the children who were at risk of impairment were not moving to that stage. They might have a consonant sound and a vowel sound, but they weren't putting them closely together in time and then being able to reduplicate them over and over again. So there's those, they were stopping on question 10 of the IMP.
Yeah. So that reflects the coordination. I mean, I'm gathering to go from a consonant, vowel, piecing it together, repeating that to what we hear is da, 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 who's going to be the first parent that their child's going to refer to, I guess, is what people refer to at this point. That part is the part that was delayed, and that was the coordination, which kind of makes sense when you think about cerebral palsy.
That's right. And that fact that it's supposed to be a rhythmical jaw opening, jaw closing movement, there wasn't that fluidity in the movement. And this is where we need to do more research, because we can't really say that we had a group of spastic CP and dyskinetic because the groups were too small. But we're starting to see this pattern emerge whereby the children with dyskinetic CP really seem to get stuck at that stage that we call marginal babble, where the consonant and the vowels are really slow. They're not coming together. Whereas the children with spastic CP were showing in that group that they were slower at getting there, but they did move into eventually that canonical vowel, consonant vowel pattern.
So they did manage to achieve that. It just took a longer time frame than the typically developing children.
That's correct. Yeah. Yes.
That's
certainly
really
some
interesting.
Of them in that group.
Yeah.
Oh, so much to think about. Lucy, any more from you?
Oh, well, absolutely. I guess, I can't help but think as the clinician when you kind of look at these results and where we stand in our role as speechies in terms of looking at early communication supports, but also identification of children with impairments. And I think reading this study as a speechie, the results highlighted for me that we can play a role in the team around the identification and diagnosis of CP, given that there are these differences in early vocalisation. And I guess in my practice, such results would give me more confidence in advocating for being part of the multidisciplinary team around reviewing particularly a 9 or 12-month-old baby at risk of CP. Is that an appropriate take-home message, Ros, do you think, for speech pathologists to receive?
Yeah, look, I think it is. I think we need to take home that there is a lot of development that is occurring in those first 12 months of life. Foundations are being laid down. And if we don't have a child referred to us until after 12 months of age, then we've missed really foundational opportunities. So, yes, I think if you have a child who is diagnosed with cerebral palsy, at high risk of cerebral palsy, then we do need to be tracking their communication. But equally, it also requires us as speech pathologists to be skilled in those early infant assessments.
Yeah, and like the first 12 months we know early intervention is vital and it's important. First 12 months even more so. And increasingly diagnosis is now occurring much earlier with the whole, general movements, and there's been such a shift there. And I guess as a non-speechy looking at all this and the role that I might have as a physio, because, we might be part of the general movements assessments. We're usually part of those teams. I think it's really important for our profession to go, okay, there's more to this than that. Communication is vital. For children who have dyskinesia, they often do develop communication. They're very intelligent children. And we need to make sure we set them up really well and making sure we're not just focusing on the physical, but knowing at that early stage is to share the love, in that sort of way and really work multidisciplinary. What are your thoughts on that, Ros? How can we do this better?
Absolutely. And it's a good question. I think it's going to evolve.
Yeah, sure.
But from observations that I've made with the babies when we were doing the videoing as well, there are behaviours that are apparent early that are maybe not evident in their vocal behaviours that show that they're really communicating in non-verbal ways. So their eye gaze, their eye shift, the intention behind that, drawing people in, serve and return of behaviours. If we can start addressing early communication as a multidisciplinary team, looking at physical positioning, those other non-verbal behaviours, how to maximise on those. And ultimately what we're hoping for is that we can determine then intervention pathways to CSP, specific interventions around communication that actually in this early stage are probably going to be multidisciplinary.
Yeah. And do you think a part of it as well, Rose, is the awareness, and we've talked about this a little bit before and we could probably talk about it in a whole separate podcast episode, the fact that speech and language development, there is a huge motor component to that. So, it's not just the gross motor skills that we're talking about, but, what your paper has highlighted is that there is a huge motor component to vocalisation as well.
Absolutely. And I mean, if you don't have good postural stability and you're not able to sit up, then you haven't developed sufficient control for phonation.
Yeah, that's right. Absolutely. And I think this is where my whole approach is very much, activity-based therapy and the move away from being very body structure and focused is that I want to encourage children that I work with to be upright as early as possible, not spending too much time on the floor, so that way they can be upright and engage. They can see people, and when they can see people, that's cognition, that's the expression, the desire to want to engage their peers, their family. And then when you're upright, that's where your postural stability can come into play. Then you might bring your hands together. And then you can start mouthing and playing and putting toys in your mouth. And again, there's lovely germs, which is why we see all those colds around the place. But, you know, all that kind of stuff comes into play. And that to me is multidisciplinary.
Absolutely. And I guess the component that we haven't touched on is that of the parent-child interaction as well, and that serve and return between a child and a parent, and that if you're up and engaging and you have that eye contact, and then you can respond to those vocalisations and acknowledge whether the vocalisation sounds like pain or pleasure, that there's power in that as well. So adding that onto the comments that you've just made.
It's putting enough weight and importance. It might not seem like rocket science that you're doing, you know, we talk about early intervention, we think we need to be doing all these fancy things, but sometimes it really is just placing enough weight and importance on the simple things, which is that lovely interaction from parent to child.
And to share that it's not rocket science, we had a beautiful moment last week where a colleague brought in her 5-month-old baby and the baby was vocalising to an adult, and you could see that she looked at the adult, told the story, and then looked back with intent to say, it's your turn. And then when she picked up an object and mouthed it, she disengaged.
Right.
And then we were talking through that as a group as we were observing it, and one of the colleagues said, oh, we know all of this, but it's amazing when you put the language on it, how it draws your attention to it.
Yeah. No, that's really cool.
That's interesting. I'm going to diverge a little bit. Just had another question. I don't know your thoughts, Ros, but also, you know, we speak about that vocal development, absolutely, and those strategies and things, and where a speech pathologist and the whole multidisciplinary team have in helping to support and encourage those strategies that may not seem like rocket science but are so important. But then also if we think about the differences at 9 and 12 months in age with increasing communication impairment over time seen in the at-risk group, because I had other thoughts in terms of the implications regarding treatments and the need to look at alternate means of communication. So, you know, such as alternative and augmentative communication supports while speech is still emerging, so that we're giving the child the best opportunity with access to language and to develop those expressive language skills. Do you have any thoughts on this or any knowledge of kind of what the research says about early access to AAC supports for children at risk of CP?
So absolutely. So we need more research. I think what we've highlighted is that there's definitely not too much out there to confuse us.
What a way to put
it. So yes, but it makes sense. We need to be looking at augmentative and alternative communication, giving access early. So 100% advocate for that. And I think, you know, it doesn't have to be high tech. We know from the beginning responding to an infant's eye gaze and setting up down the track potentially for future eye gaze technology or whatever is appropriate. So yes, augmentative communication. I guess the other side of me too is that if we develop more skills in eliciting and shaping vocalisations, then we're also maximising the child's potential, because communication is multimodal. And so if we also invest some opportunity in shaping those vocalisations, although it may not be the child's main form of communication, it does give empowerment for maybe accessing your communication device. Does that answer your question, Lucy?
Absolutely. That's a really good point. And I think highlighted that shaping in terms of imitating, modelling, all of those things that we have, those speechy kind of terms we use in the early stages are setting them up so are part of that early intervention, which will set up for more of that multimodal communication if it's needed. So thinking about those in the early stages is vital.
Yeah.
Absolutely. That's great.
Oh, so much good stuff.
I know. So, Ros, how would you like to see the findings of this paper implemented within current practice?
I acknowledge that it's a small sample size and this is just the beginning, but I think it highlights we need to start tracking communication development early so that we can see departures from typical development. And then if we do that, then we can start to look at targeted interventions to address where that departure is occurring. I acknowledge that early communication development in typically developing children is also highly variable. So it might be that there are some children who get access to a service that are going to maybe get there just a little bit slower than their peers. But I think we've already come to the decision that when it comes to at risk of cerebral palsy, that some false positives are okay.
Yeah, absolutely. Right. And, you know, as you said a little while ago, there's not a huge amount of research in this area. So this question, again, could probably be a whole nother podcast in itself. But if you, I suppose, had to pick kind of one or two main priorities for future research, what direction would you like to see future research going in?
I'd like to see us go for a larger sample size. So let's replicate this again with more children to see if we can start to develop enough data to start to determine pathways. We're also continuing to delve deeper into this data. So we've talked about the IMP, but we've also been collecting infant vocalisations to start to see whether we can see markers in those vocalisations that will give us more information. So I'd like to see that research continue. And equally also, let's start targeting some interventions and see if we can make a difference.
Absolutely.
Yeah, a lot of exciting things to happen. But, I think, Lucy, I think you've got a few things to ask as well.
I was just going to say, Ros, I was make a comment. I think, that second part that you were saying there, that the paper is just so clinically useful already, even with that smaller sample size. So thank you, for doing this work and sharing such knowledge and data that can now influence everyday practice. And I think that tracking early vocalisations and then getting in early is something that all speeches can take from this. So thank you.
Well, thank you. It's always wonderful when you hear it's clinically meaningful because that's why we do this, right? We want to change clinical practice that our families benefit.
Yeah, that's wonderful. Well, now we're going to head to the next segment where we can really put it all together and how we can summarise this research to everyone. So this is the segment commonly known as Tell It to Ed. Now, as you know, Ed is our producer and he doesn't have a background in child health or in speech and vocal productions. So it'd be really wonderful to hear what it is that he takes from this. So Ros, in about 60 seconds or so, can you summarise this research and Ed in turn can ask a question?
Okay, my summary is this. Babies are set up to learn and the first 12 months of life represent a critical period of development for language acquisition. Within adequate experience, at the right time points in development, such as through a sensory deficit, for example, hearing impairment, insult to the brain, or reduced parent-child interaction, children are at high risk of lifelong difficulties. Early identification of the risk of communication impairment is possible through the assessment of infant vocalisations and fundamental to maximising a child's communication potential through access to early intervention.
Oh, lovely. I love it. All right, Ed, over to you.
Very, very insightful. And I say this about every episode that we're doing, so I'm learning a great deal. Obviously, I don't have a background in healthcare, but I find a really interesting parallel between the early intervention part and something I'm relatively passionate about, which is music. I have like a small degree of perfect pitch, so I can recognise certain notes but not all of them. And I think a lot of the thinking behind that is that you have to learn that at a very, very early age. If you don't develop it by 2, 3 or 4 years of age, you'll never develop that. So my thought is there a window like that for children who have communication difficulties? Is there a window where you can miss it? Like, is the early intervention window very short? Is it very broad? Is it? Sorry for my ignorance, but
no, it's a really insightful question. And absolutely, the literature does talk about these sensitive periods of development, and they have labels for what occurs in these early periods. So, when I talked before about sound specific, how it was universal production, well, there's a phase where babies are starting to tease out what language is important to them and what they can let go. And so the literature argues that there are windows around that.
Okay.
But the exciting thing is they don't have to close if we intervene, potentially we can extend those windows.
That is exciting.
That is really cool. Yeah. Great question, Ed.
Your excellent track record continues, Ed.
That's great.
Well, I do want to thank everyone for their time today. And I really want to also thank all the listeners who do write in to give us some feedback. I do really appreciate it. We find there's great value in this. And if you keep finding great value in it as well, we really do appreciate that feedback. And if there's other areas that you're really interested in, please do let us know, because we do this for you for more than any other reason.
Absolutely.
So definitely do write into us, and we do appreciate the comments, and we've been trying to angle things according to where people have wanted us to talk about as well. Yeah. But thank you so much, Ros, for being here to share this wonderful study. And like Lucy said, it's got so many great clinical implications, and congratulations on such a huge body of work.
Well, on behalf of the team, thank you very much for having me here today. It's always a pleasure to talk about what you've been spending your time researching. So
that's right. And Lucy, thank you so much for joining us all the way from Melbourne, and
you're welcome.
Your insights as well.
No, thank you so much. That was fun. Thanks for having me, Ros.
Nice to see you again, Lucy.
Take care, everyone, and we will see you next time.
Next time, guys.
Bye.
Thanks. Bye.